also, I think, a very interesting adventure in healthcare informatics, as you're going to learn about today. Our speakers are Dr. Amy Chaumeton. She is internist by training. She is Chief Medical Information Officer, Chief Medical Informatics Officer. Also, she's board certified in internal medicine and in clinical informatics. Her med school is from here at OHSU. Her residency is from Legacy. She's also a double duck, she told me. And so she is as local as it gets. And John Kenagy, Dr. Kenagy is Senior Vice President and CIO of Legacy.
You are so good. All in memory.
The C-suite, you can't get their titles wrong. And also, you know, he's well known to us because he's faculty here at DMICE, and many of you have actually taken his excellent business and informatics course, which is offered this summer.
Good ad, thank you.
As I'm
starting
proud to
June 27.
And then he's an engineer by training from Stanford and has a PhD in IT management from Capella University, and then something else that I forgot again.
Masters of Health Administration.
Masters of Health
And Joan Ash was on my dissertation committee.
And John has actually been at OHSU before and at the VA and at Providence, so comes to Legacy with an extraordinary perspective on both healthcare as well as the management of IT in healthcare. This is a clinical informatics grand rounds, and therefore it is eligible for 1 hour of AMA PRA Category 1 credit. And if you're a physician and you wish to avail of this after at any time, email Lynn Schwabe at schwabel@ohsu.edu. And for those of you who are outside, I actually wrote this down because I can never remember it. If you tweet to @OHSU Informatics with the hashtag DMICEConf, we can take your questions if you have any at the end of the talk. And so with that long-winded introduction, welcome, and I will cede the floor.
So welcome to OHSU's water birthing class. Actually, it's not water birthing class. We're going to be talking about, and everyone on the audio audience just didn't get that joke, but there was a sign when we walked in, water birthing class. So I'm John Kenagy. Thank you very much, Vishnu, for having us, for having both Amy and me here. We're going to talk about the EMR adoption model and the journey that organizations take in EMR adoption. But I'll start with a little bit about us. Thank you for mentioning. We added this picture. Silverton Health down in Silverton is the rural health system that just joined our family officially yesterday. June 1st was our kickoff. We have 2 urban hospitals, Legacy Emmanuel and Legacy Good Samaritan, 3 suburban and now in a rural hospital, and the Children's Hospital. Very large system. Last year, Legacy took the #1 spot in terms of market share in the local presence. Of course, we compete with Oregon Health and Science University and Providence Health and Services and Kaiser, but we're locally operated here in the Portland area. We have a hospital up in Salmon Creek. Is the name of the hospital in Vancouver, and we've had a long EMR journey. We are on Epic, so we started the Epic journey around 2008 in conceptual basis. I was here as OHSU's CIO when we did Epic for the Center for Health and Healing, and then turned over to the hospital. And I, from that conversation and from that interaction with Epic, just became a Epic true believer. You sort of join a cult when you work with Epic. They are an amazing company. But what we want to talk about here is accreditation and this EMR adoption model. So HiMSS, just definitions to start, we'll use the acronyms a lot. HiMSS is the Professional Society for Health IT Practitioners. It has both vendors and practitioners like us. It is the Healthcare Information and Management Systems Society. And a number of years ago, we'll talk about the history, they adopted this model called the EMRAM, or EMR, before EHR was the, or HER, if Microsoft spell checks your acronym. EMR adoption model is what we're going to be talking about. But what I wanted to start with is just audience participation. What designations or accreditations are you familiar with that hospitals seek? You probably have badges on, or big banners on OHSU Hospital or Dornbecker Hospital. Any you call out any that you know of? JCO, the Joint Commission.
No longer JCO.
Right, TJC. There are lots of them. There are lots of them around that are awards and designations that a hospital will go for. EMRAM is one of them. Legacy has a number of these, and so just to set the stage for sort of these, the idea of having external accreditation come in and look at your standards. Obviously, the College of American Pathologists, if you're running an accredited lab, you need to have a survey, as we mentioned, the Joint Commission. Joint Commission also has centers of excellence, so do a lot of health professional societies and professional organizations. So not to be outdone, the HiMSS Professional Society for Healthcare IT adopted this model for healthcare. And let me turn it over to Amy, who talks about what stage 7, the highest stage, means.
So I think the slide says it all. It's paperless, so I'm done visioning. What are you going to lunch now? Just kidding. So just again, a little bit of background. So as many of you know, HiMSS is a nonprofit organization whose goal is to promote the best of information technology and management systems in the healthcare industry. And their vision is really around improving health through the better use of technology and information. And so they have created this adoption model for the EMR, the purpose of which is to ensure that the most relevant clinical information is available to the clinical decision maker at the right place and at the right time. So that's the ultimate goal. So they created this model for the acute care setting in 2005, and it really reflects a typical manner in which a hospital system might progress toward a paperless system, and introduces the concept of this roadmap. They subsequently developed an ambulatory model in 2010, and now they have a continuity of care model, which they developed in 2013. So it's a progressively sophisticated model, starting with those systems that have maybe lab, but not pharmacy, or maybe radiology and lab, but not pharmacy, or whatever, and progressively gets more sophisticated as you go up in the stages. Now, interestingly, this is not a static designation. So when we validated for stage 7 in 2013, we met all the criteria. Obviously, we became stage 7. We are now looking at revalidating, which you do every 3 years, and new things have come along. So blood product administration module or blood bank matching is new, so that's something that we have to raise our standard to in order to meet stage 7 at this time. Breast milk scanning, and another one that came up in between our validations was the barcode medication administration in the ED as well as everywhere else. Oh yeah, go ahead.
Just before you finish your thought, but before you go to the next slide, I want to.
So there's, and then the other piece of this is that in January of 2017, HiMSS is looking at releasing essentially different criteria for all these stages. So progressing the model forward, and I believe stage 0 essentially goes away. So stage 0 will then be the ancillary lab, radiology, and pharmacy all installed will now be stage 0. So not all the stages come down like one step, but they're making the model more sophisticated.
Just one question. Where do you think American healthcare, most American, we have 6,000 hospitals in America. Where do you think most hospitals are in this? Stage 3, one guess. Others, stage 4, stage 1. Hospitals, because it's an acute care model.
We'll get there.
We will get there.
So just to give you a little more detail, and this is not the fine point detail, but to give you an idea, for stage 1, it's all those ancillary systems, as I noted before. Stage 2, clinical data repository. Stage 3, you have nursing documentation, and also PACS is available throughout the hospital. Stage 4, you have CPOE and alerts going. I think the criteria is like 50% CPOE. It's not what it is at stage 7, but at least gets you in the game. 5 is full PACS. 6, barcoded medication administration, and also discrete documentation, so structured documentation for physicians, so that you can actually start to get them some data from their documentation. Stage 7 is quite the checklist, but the biggest part of validating for stage 7 is actually being able to tell your story, that you can actually use the data that you're collecting in your system to improve patient outcomes or business outcomes or patient safety. You have to show that you've changed your transcription rate. So Legacy went from having somewhere just north of 100 transcriptionists, and through our Epic journey, we actually use less than 10 now as part of that journey. You have to just show that you've made that conversion, that docs aren't just doing the same thing as they were doing before you implemented your system. It's generally paperless, but as you know, paper comes into the hospital, so you just have to be able to show that you can scan in a timely manner, that no clinical data that's important would sit in a scanning basket for more than 24 hours, and then other relevant or non-clinically relevant consents and such would be scanned within 3 days. You have to show that you have device integration, hopefully more than just in the ICU, but that's the benchmark, is that vitals are integrated in the ICUs. To show interoperability, so Care Everywhere is great. If Care Everywhere is only exchanging with other Epic systems, that doesn't count for this for stage 7. You actually have to exchange with a non-Epic system, at least one, and that bar will go up as well, I'm sure. All medications in Epic. Even if a code is done outside of Epic, you have to show that information gets put into the record at some point in time. So it's important that you can then look at the full patient record and see what medications were administered through their hospital course. You have to show that you're using CPOE 90% of the time, that you don't have a culture of doctors walking by and giving verbal orders. That would never happen, right, Tim? Ever? Never. Electronic repackaging verification, 95% on barcode medication administration. And what this means is that they at least tried to scan the medication in the patient 95% of the time. It doesn't have to be successful, because as you know, for multiple reasons, barcode medication administration scanning is, if the label gets a little upset with a little bend in it or something, they don't scan very well. And then, as I mentioned earlier, the breast milk and blood scanning. For ambulatory, stage 1 is access to clinical information. Stage 2, again, the clinical data repository. Stage 3, clinical documentation with some decision support and in-basket functionality. Stage 4, again, CPOE with e-prescribing as at least being available. And then stage 5 is much around the patient health record and what you're doing in what we would call MyChart. Stage 6 includes some best practice advisories and health maintenance modifiers and patient reminders, so reminding patients to come in for their health maintenance, such as a colonoscopy. And then stage 7, interoperability, data analytics with the Cogito tools in Epic parlance, collaborative care scenarios, Care Everywhere exchanges, as we discussed in the inpatient realm, and then more than 95% CPOE for ambulatory setting. So why? Profile of a stage 7 organization is to use data to drive improved outcomes related to processes, financial, clinical, quality, and safety. And it's essentially paperless. At least all clinically relevant data is within the EMR. And you have to show that your organization is fully committed to the continuous process improvement through collaboration with your strong IT leadership and good clinical end users and champions. So, getting to John's question, the majority of hospitals are at stage 5, with many moving towards stage 6 and stage 7. And then you can see on the ambulatory side, the majority is actually down in stage 1 and 2, but moving forward.
But still, a couple things. One that I would add to this. No, I got it. One of the things that surprised me is still 2% of hospitals, 2% of 6,000 hospitals remain without lab, radiology, and pharmacy, all three of them. I mean, just to have those which have been around since the 60s, to get to stage 1, you have to have all 3 of those. When HIMSS got involved with the incoming Obama administration 7 years ago, when we were putting together the work on ARRA, the American Recovery and Reinvestment Act, which provided the funding for meaningful use of certified electronic health records. So the folks from the incoming administration called HIMSS to say, we want to invest money and we'd like to get electronic health records across the board and certainly get CPOE and closed-loop barcode medication administration. But to get to stage 4, where you have physician documentation and pharmacy online, and what that would cost. And so that's where the $20 billion from meaningful use. The goal was to get every U.S. hospital to stage 4 in the course of the life cycle of the HITECH Act. And we did, and there's still about 20% that is less than that. So,
anybody have any idea of
hospitals.
how many Oregon hospitals are stage 6 or 7? What percentage? More than 30%, more than 40%. I mean, so stage 6 and 7 across the U.S. is at, what, just over 30%?
What's the optimistic? 80%.
Okay, verdict says 80? Okay.
There are
So there's
5 U.S. hospitals.
No,
5
well,
Oregon.
stage 7, but if you include stage 6, so 30 hospitals, there's 65 hospitals in Oregon, so we're dang near 50, not quite as 50%. We're headed there. So pretty good adoption in the state of Oregon.
Those 5 hospitals, 4 of them are legacy and 1 of them is Kaiser.
Correct.
OHSU is not stage 7 yet.
So I thought it was pretty cool. So this shows how long it takes to make national progress. So over the course of 9 years, we've taken the majority of hospitals have gone from stage 1 and 2 to stage 5 and 6. Pretty impressive adoption rate over time.
It's still a very,
Do you get a sense
That's
that there's
right.
a plateau? Like, is there a particular stage at what hospitals kind of get stuck, where there's like an operationalization gap?
I think that's a great question. I think CPOE, to get to stage 7 of 90% CPOE is hard. I think that's a real physician order entry. I think is a real high hurdle to hit. I think that the could you let me see, go back. For us at Legacy, and here I think the at OHSU, I've talked to John Dunn a lot about sort of our journey, and I think OHSU is stage 6. The scanning, so the amount of paper, like in the behavioral health units, barcode administration, medication administration in behavioral health, and there's sort of the amount of paper. You really, to get from 6 to 7, is really sort of no clinical paper generated. That is a very high bar.
How are those? Is it the data? Is it the right data to use your denominator, the number of hospitals or number of hospital beds? Because again, if you have 20 hospitals that have 30 beds each, and that's only 3% of the hospital beds in the state, I think it's a much different.
Yeah, I think you're right. I think certainly academic medical centers have historically been high on adoption of IT, large systems, Epic systems, which of course Epic sells generally to the large, and then it's us who have to host for a smaller. But I think you're right. In terms of U.S. beds, I bet that percentage would be a lot higher.
I was just going to say, though, I'm not sure. It depends what you're looking for, because the hospitals might be a better representation of patient access to, high-stage hospital care, right? I mean, yes, they might only have a few beds in some rural place, but that's serves that whole community.
It could be a critical access hospital still, even in a small area, but that's where it'd be more interesting to sort of tease this out, because if you're going to try to get everybody up, you have to figure out why are the people lagging behind, and is it because of hospital size, critical access,
Right.
or whatever that may be.
I think there's a huge barrier, of course, of cost. So for Legacy's journey was about $100 million in capital and another $100 million in operating. So about the budget for Epic was about $112 million. We finished around $93 million, so we came in under budget. But for us, the meaningful use dollars represented about $40 million. So it's really, and that was my experience at Providence, and I left here before we got meaningful use dollars in. But roughly, I've heard that average that about 40% of your costs in EMR implementation will be covered by federal grants through Medicaid and Medicare through the meaningful use program. But you have to come up with the 60%, and that's a lot. At Providence, our investment was just north of $1 billion.
Still cost was 100%, and hope you get the 40% a couple of years later.
Yes, yes.
The 40% is not given to you up front. It's
Correct.
recovery a couple of years later, maybe.
I think that's the other thing for ambulatory is the doctor's offices that have to, adopt. And now with MACRA, I mean, they're more just for private physicians in private practice. EMR adoption is a high bar. We host for a number of physicians. It's a $5,000 upfront cost. It was $15,000, and we're reducing that as we donate through a program that Legacy offers. OHSU doesn't offer that to private physicians, but there's just a high hurdle. The other thing I think that's a hurdle is stages of EMR. So Epic was our third EMR. At Silverton, which will go on Epic in about 11 months, they have 5 current EMRs. We're just talking to St. Charles and Bend. Both OHSU and Legacy have been friendly, brethren to the St. Charles facility, and they have decided to go Epic. Epic will be their 4th EMR in the last 7 years. So it's just so highly disruptive. I think people are scared of it, and it's a lot of money and a lot of organizational risk. But done right, it can really mean a good difference.
So this is what it looks like internationally, and interestingly, a little bit later I'll tell you about a journey to China. Their adoption is coming along, and they're very interested in this model internationally now as a benchmark. So it'll be interesting to see how this changes over the next 10 years. So the road to stage 7. So to do stage 0 to 5 is really a online self-assessment. So it's you answering questions about your system and organization, and it places you essentially in a certain stage. When you get to stage 6, you continue to do that online assessment, and then you apply to essentially have a verification call where you get questioned pretty comprehensively about your system and such, and then either do or don't get awarded stage 6. For stage 7, it's those first 2. It's the online self-assessment. It's a telephone call, and then you have if you have met the criteria, you then have an on-site visit with 3 reviewers, including a HIMSS representative, an active CIO, and an active CMIO from other systems. So it's a reasonably rigorous day of showing off your system.
I'm more sedentary, but both Amy and I are HIMSS 7 evaluators.
Yeah, we'll get more
You
to
said
that too.
active CIO.
Yeah. Oh, thanks. Mm-hmm. So this is just an example of the day of the visit. So you actually spend the majority of the morning sharing your story, including how you've used your data and analytics to improve care and to improve your business operations. So that's actually quite, in my parlance, it's actually quite a fun piece of this because it actually celebrates the work that you and the team have done over time. And when you go back and look at how much you've accomplished, it's actually really great for the group. You then start doing floor visits, and the group of 3 goes on to the units and starts looking around for paper and starts asking questions. And I'll tell some more stories about that later in the presentation. They do take a good look at your medical records department because there's a lot to find in there. The emergency department, you go to pharmacy, radiology, you actually go to lab. I missed that on here, I apologize. And then the reviewers go off into a secluded room and make their decision as to whether you have successfully achieved the criteria for stage 7. Yeah.
What's the success rate when you get somebody to come out and do that? I mean, do they?
It's reasonably high, but because they do that pre-call to make sure that you're actually on track. But I can tell you that some of the visits that I've been on, the team has been running around because they haven't really made their case in that first presentation as to how they're actually using data. It's really interesting how hard that is for some teams to relay, even though, I mean, they have scads of data and they're doing all sorts of stuff, but actually to really present that and show how it is affecting patient outcomes or business outcomes or whatever, you know, they're trying to prove. It's actually harder than one might think. And so I've actually, out of the 3 reviews I've done, 2 were pretty sketchy for a while until we really got them. But the team was like, as you're going around and you're on the wards and looking at stuff, if you've told them after their presentation that you didn't quite get this piece, or one of them was, with ours, it was actually coming up with a story around our disaster recovery because our backup servers are in the same geographic location. They're in the same zip code. They're only blocks away. And that was an issue for the reviewers. And so coming up with what our strategy is to deal with that and where we will be. So
I did the multi-care review. Multi-care is a system sort of like Legacy in Tacoma, and they were only evaluating one hospital to be stage 7, and it was sort of their lower acute, not their main hospital. And what we found was there was paper, which is okay, clinical relevant paper generated. And they had HIM come through, and every day, twice a day, would go through the hospital and bring it down to central scanning and put it into Epic. But they didn't do that route. They didn't do that run on Saturdays and Sundays. And the requirement is that anything that's clinically relevant that's paper is online within 24 hours. And so we didn't pass them. But we said, if you certify, and then we had one of our reviewers go back to confirm. But if you actually just start that HIM going around Saturdays and Sundays, we would. I mean, it was right. So it's a rigorous. But I would echo Amy's point that there's so much. You know, this is the organization doesn't have to pay for it. HiMSS Analytics pays for it, except the recertification the organization has to do. So HiMSS is putting a lot. They pay our travel and expenses to go to the site. So it's a fairly extensive. It's a lot of money that HiMSS pays. So they want to make sure you're really ready before you do the on-site evaluation.
So what is the motivation for the hospital to go through this rigorous process? What do they get in the end for it?
Here's my slide on the next. One of the things that I think that is important is that it is a national benchmark. So you can guide yourselves against something that says basically on a journey for electronic health record. It's one of the things that I struggled with in coming back and presenting. It's a plaque that goes in the lobby of all of our hospitals. It's really beautiful. It's a nice thing. And I'm going to the medical executive committee and I'm saying, hey, we have really high level of adoption. We're paperless. We're at the point 2.5% of U.S. hospitals had achieved it. And I said, I know, speaking to you all physicians, you think our system sucks. So it's hard for me to, I recognize this is a journey and we need to continue to improve usability and the flow and the design. Electronic health records still are in their infancy. There's a huge dependency, of course, on them. But having a benchmark, I think, is wonderful. It is an externally validated measure of excellence. So your achievement, I think there's this other one, the recognition and celebration of incredibly hard work. To really get to that point requires clinician, leadership, technology, this amalgamation of a lot of people working really hard. And the higher EMRAM designation and the stage 7 has led, and it led to us as well at Legacy, better bond ratings and lower malpractice insurance because it is externally validated. So the next slide is our attempt, because
At humor.
we're unhappy. There's the healthcare is most wired, so this is self-report only. There is no validation. And so I've tended to call it the most liared, because if you are sort of you're sort of stretching the truth on how fabulous you are in an electronic health record. The year that we received the stage 7 across all of our hospitals and ambulatory clinics, the first organization to get both, we did not get the most wired. I'm like, okay, there's something odd about that. But let me continue to go on in terms of what have studies. Now, they're still coming out with this correlate a stage 7 hospital with better quality, lower mortality, better profitability. And this is what the slide, so in terms of, Joan, your question of why would you do it? First of all, there's why would you want to achieve the paperless, and I think that is the goal. For us, our $100 million investment was moving towards healthcare that is driven by better information and better technology, and that has translated to organizations around quality. So this is the Joint Commission, the Joint Commission's quality measure performance, and there are a number of measures with 3 or less or 4 or more of the measures met, and you can see that there is a correlation, not a causation potentially, and so maybe higher performing hospitals also have a lot of other things. It's not causal, but it's correlated that higher stage hospitals perform better on the quality measures for the Joint Commission. Another statistic is the Leapfrog group. So Leapfrog is an association or an organization of self-insured organizations. Boeing is a very large member in our I think Intel is actually part of the Leapfrog group. So representation of hospitals with an A Leapfrog hospital safety grade, and where of the hospitals that are in the A grade, 62% of them, or 2/3 of the hospitals are in EMRAM stage 7. Medicare did the value-based purchasing, which is also a quality measure of having this score in the value-based purchasing, and sort of where the organization is, and sort of middle-level performance when you are lightly adopted of an electronic health record, but really mandatory use, and across the board there is a higher percentage in stage 7. Mortality rates driven by health grades, so health grades looking at predicted mortality and MI and respiratory therapy, and looking at actual mortality in a lower EMRAM score versus higher has shown to be reduced. And then finally, profitability, financial performance. This was measured, I don't remember the source of this one, put it down, but in terms of higher profitability, the operating margin for organizations has appeared to be higher for organizations that are in stage 7. Please.
You mentioned the question of causation versus correlation on these, and I think that deserves a little bit more discussion maybe, and particularly this one where, higher performing organizations financially may just have the money to
yes.
be able to implement really high quality IT.
Causation could be the other way around.
To do this,
yes.
Right? And then the other ones, it may just be a surrogate marker of high reliability organizations in general.
Yes, yes. There was a study, one of our doctoral, I think he finished the doctoral, one of our first doctor students, what was his name? Anyway, doesn't matter. He was one of when DMICE started the doctorate program. He was one of our first students, and he attempted to do Adam, thank you, Adam. Worked on research on looking at stage 6 and 7 versus quality measures and external measures. and my point after, and it was not found. It was not found to no correlation between 6 and 7 hospitals and quality and all these other measures of success. My point to that is 6 is a fairly low bar. So if you have CPOE in just the ED, you can get stage 6. 7 is CPOE everywhere, 90% adoption. So I think safety, the higher bar of 7, even though there are fewer hospitals, I think is 6 is just too open, I think, to necessarily, and he didn't find 6 and 7 hospitals were not necessarily better quality than lower EMR adoption. But it was also, that research was done maybe 4 years ago, and EMR use, it takes time to become really facile in using it and have the implications and develop the data to be able to run quality surveys and really promote quality. So I think you're very much right on that point.
Well, the other thing I'd say too is that a lot of the quality and process measures are captured out of a system that's designed to capture the data irrespective of whether the data are accurate or not. Mm-hmm. So for example, there's been plenty of studies, for example, which show that everybody, regardless of what smoking cessation they got, or counseling they got, have the box checked on admission. So if you have an order set that's put in as part of stage 7 that has an automatic pre-checked box, your process and quality measures will go up dramatically, but that does not necessarily represent outcomes. And the best example of that were CLABSI rates in the United States, where as soon as it became part of meaningful use, the incidence and prevalence of CLABSIs dropped by 90% in 3 months after 10 years of stability. So again, realizing that when systems are designed to improve reporting of measures that then are used to determine the effectiveness of the system, it is a self-fulfilling prophecy in many ways.
That's a really good point.
Not to be a nihilist, but.
Still want the EMR journey. I remember the doing our survey, and the point about how often is it sort of touch and go. And I wasn't in the room. Were you in the room when they did they were in imaging? They did the survey of imaging. So the surveyors are going in and talking, and one of the radiologists says, "I'm glad you're here. I hate Epic. Let me just tell you what I just don't like about this. Needs to change. This needs to change. Our PACS integrated, and our people that are accompanying are like just, oh God, he just blew our."
We were completely mortified.
It was just there we go. We're not going to be stage 7, and the surveyor said, well, do you use it? It's like, well, of course I can't do clinical care without it. And I'm like, okay, yes, it needs to be improved, but you're still using the system.
He then proceeded to show them how integrated the system was and how well it actually works between the two systems. It was actually quite funny.
So as I said, Amy and I are both, we have been independent CIO, CMIOs evaluations. And so I've had the pleasure of looking at a number of sites in this order: Stanford Hospital, UCLA, Cedars-Sinai, and Multicare up in Tacoma. They were all really interesting. They were all Epic, all of them Epic, but not all Epic, of course, is stage 7, and not all stage 7 is Epic. There are not too many, but there are some Meditech stage 7, and I think Cerner has a few as well. But really good programs. But about the week, or maybe right around the time that I was invited to go to Tacoma, then they called Amy and said, "Would you go to China?" I'm like, "Okay, I'll go to China. You go to Tacoma."
Jealousy is rampant. So I've had the opportunity to go to Sutter Health for an ambulatory visit, Cleveland Clinic for an ambulatory visit in Shenyang, China, which is kind of near the North Korean border, to do both hospital and inpatient, and it was amazing what they have done. I'll show you. These were a couple of the nurses I met. And so it's just important. I was just going to tell a couple stories about some of our reviews, but one of the things is preparing your staff, and we thought we had prepared our staff quite well, and we even, you can choose a little bit of who's around or which radiology department you go to or whatever. I mean, right? That didn't work so well. But on one of the wards at Good Samaritan Hospital, we went up there, and the reviewers are going around, and they're asking think it was an LPN actually, what do you do in downtime? And she said, well, I go in and I tidy up the patient's room and I make sure that they have anything that they want, fill their water, pick up the newspapers. And they're like, no, when the computer's down and you can't utilize the computer, oh, I just go over to another computer and I start typing. Our daytime staff had not experienced a downtime in so long. They didn't even know what it was. And so it actually brought up process for us. We now actually are doing more downtime training both in the evenings and during the days.
The question, downtime to mean
when she's not active.
Your downtime. What do you do in your downtime?
So it's hilarious. Interestingly, in Shenyang, they have a vendor who actually employs 20,000 people, 20 of which are on site at this hospital. This hospital is quite busy. They see upwards of 1,000 patients in their ED on a daily basis. That was a daily basis. They see tens of thousands of patients in their clinics every day. And in fact,
just for comparison, what's an emergency department like OHSU see in a year? Like 30, 50?
Yeah,
50,000, right? So 50,000, these guys are seeing 1,000 a day.
right. So things have to be efficient. And one of the things I was most interested in is I spoke to some of the specialists that we met with was how many patients a day are the specialists seeing, and that ranged from 50 to 100 patients a day. I can tell you they're not held to the same documentation standards as we are here in the United States, but they are putting good information in the chart. I mean, it's very clinically relevant, it's shorthand, whatever, but they are documenting, and they don't have to worry about what needs to be in there for billing or such. So 50 to 100 patients a day. So they took us to the outpatient clinic. It's a big tower of a building, and you walk into the building and there's hundreds of people waiting to get on the elevators to go upstairs. And they walk us around. We're like this special group. It felt really weird. But so the reviewer group gets walked around to a private elevator, and we go straight up. You come out onto the floor, and it felt like an airport. There was airport seating. There were monitors everywhere to tell patients who the next patient up was or the next couple patients, so you could kind of monitor the progress of that provider who you were going to see. There were kiosks for the patients to make appointments, for them to print out their prescription after their visits, or to send their prescription down to the pharmacy. If they chose to use the pharmacy in that building, they then would get a text message on their phone, if they so indicated on the kiosk, as to when their medication was ready. It was amazing. I mean, the experience was truly amazing. Their clinical rooms, I have to tell clinicians in the room, but was literally a desk where the doctor had their computer, and in front of the desk was a stool. There was a little sink in the room. You wash your hands and watch. There wasn't a lot of medical equipment. There wasn't a lot of comfort. If it was in the gynecologic clinic, there was a back room to take the patient to if they needed to do an exam. But privacy was not a high point, I would have to say. Interesting experience. Another journey in China that I think would be interesting is the one thing that they hadn't really figured out was the disaster recovery damage. Their system was up 90-some%, very high 90s% of the time. But the chief residents were the ones that would back up that floor's data when they went home every night. They all had these thumb drives, so they would actually do the backup, and that would be, so if the system went down at any point in time, they're the ones who had all the information. So I went to an OB ward, and the ward was made to hold, I have to get this right, 20 patients, which would have, there are 20 rooms to hold 40 patients with 2 beds in each room, and they had put a 3rd bed in each room, but there were 66 patients on the ward And so those additional patients were actually on air mattresses in the hallway. It's how busy they're and they were, I mean, they're churning them through. How many patients did that chief resident have? Everybody who was on that ward, 66 patients. Wasn't clear to me how many interns or residents she had to assist her in that journey. But just the sheer volume of patients in this place was something that we truly want to understand. Another interesting piece from that visit was length of stay was much higher than ours, in the over 10 range for many different kinds of patients, because the clinic docs would actually admit patients if they needed a surgical procedure, because the process of getting the surgery approved and dealt with was much easier to put them in the hospital, have the patient actually wait in the hospital to get the procedure than actually to schedule that as an outpatient. So again, different system, and they work around it as they can. Just because docs are seeing 50 to 100, you ask, you're like, how do you do that? And one of the pieces was this is a big city where a lot of people come for care from rural areas, and one of the docs said to me was, I don't know how far that patient has come, and I don't know, if they have any place to stay for the night, or I just don't know what their social circumstances are around this visit. So I always feel obligated to see them. So if there's patients waiting, they just continue to see them because they don't know what potentially difficulties the patient would run into if they said, no, you need to come back tomorrow. This is just a screenshot of their electronic health record, but the piece being that they actually had some pretty, this isn't a good screen to show it, but unless you read, Vishnu, do you read Chinese? Okay. But they were doing a lot of structured documentation. They had a lot of shortcuts in their documentation to pull stuff up. They were very careful with how they did that, interestingly, making sure that the record was accurate. This is to remind me of something I learned from Dr. Richard Gibson. As I was on a visit with him at Sutter Health, and we went into the medical records department, and I don't know how many of you know Dick Gibson, but he's just a wonderful guy, and he starts like going through this stack of things that need to be scanned, and I'm like, what's he doing, And he's looking through, and he pulls out like a physician note, and he's like, what's this? And they're like, And so the piece being that the documentation, it needs to be in the electronic health record, and even if you scan it in, if it's done in your facility, it really should be done in the record. And so he really taught me a lot about doing reviews and how to look for different pieces that people may or may not know about. He was telling me about a visit he did early in his doing visits, where he went into the site said that their radiology was all digital. They were sure of it. And then they go into the radiology department, and there's one machine that's putting out films, and of course he finds it. He's that kind of guy. So he was actually a really good mentor for doing these visits because of how detailed he is and how he looks into stuff. And then this is the journey that we're actually embarking on right now is blood product administration and the matching out to the blood bank. So we scan all of our blood products currently, but it doesn't match back out to the blood bank, which is an extra patient safety piece that we would of course like to do. We're struggling a little bit because we have Cerner on our lab side and Epic on our clinical side, and we don't want nursing to have to go into yet another program, which would be Cerner blood product administration module, to do it, and Epic and Cerner are actually having some trouble talking on this. So our journey to our revalidation is a little stilted right now. But do you want to talk about some visits?
Yeah, I think, just even our own and others. You asked what does the organization get out of it? And I think I've heard the same for organizations that are looking for the Baldrige criteria. The value for us to not only reflect on our journey, but also document what we had done was a great internal, it was a motivator. For us, it was definitely a motivator to accomplish some things that we wanted to accomplish. It was certainly ways, we got a lot of data to heighten. We had a couple hospitals that weren't meeting the barcode medication and the CPOE percentages that needed to be achieved, and so got the visibility and encouragement to get that up, which we do believe correlates with safety. And so I think we're really good. Just sort of going through the process itself, I think, had positive consequences for our organization. I have enjoyed going through the other places. I learn, as you noted, particularly I've done just Epic US visits, but everyone does Epic a little bit differently, and so some of the things that I saw that were really great have facilitated cross communication between Epic customers. And kind of, oh, that was an interesting, very novel approach to it. Can we talk more about it after the visit? And so the Epic family is a very close-knit family to begin with, but that's been a really neat part of doing this.
Silly question. Once you make it to a certain stage, do you ever get downgraded again? And what?
Yes, we're close. I mean, we need to revalidate this year. We'll potentially go down to stage 6.
So how often is the revalidation or the recertification?
Every 3 years.
And how much does it cost to get an organization ready for each one of these site visits? So again, is this, it's sort of like, JCO was done by hospitals for hospitals and ends up basically, again, becoming this self-fulfilling prophecy. So, what's the optimal time frame? What are the resources that are required? So how much, it's one thing for a hospital to get ready. How many hospitals are going to continue to do this every 3 years versus saying, hey, we got this bar, this is what we need to do, we're done with this?
I think because it's an evolving model is why I continue to be excited about revalidating, because it actually continues to keep us at a certain level. As I say, we're struggling right now to do this. We're in the throes of it, trying to revalidate in October. It's great for the team, too. I mean, it's just one of those things to work towards. But as John says, I mean, our team, the excitement around the IS and informatics team, and honestly the clinical teams as well, was so worth the journey. How much time? It's part of our directors meeting currently. It's really not that big of a deal. We already had the CPOE reports written, the BCMA reports written, all those things that you have to go back and make sure you're still holding that standard. And then as you do the gap analysis, I mean, it didn't take me very long to do the gap analysis, partly because I'm a reviewer, so I've kept up on it. But, so there was the gap analysis, and then there's a couple projects, some of which we'd already done. We'd already done the breast max scanning. We'd already put barcode medication administration into the ED. And so this is it's not our only hurdle. So one of the things that's occurred in a couple of our ICUs is multidisciplinary rounding. And as a part of multidisciplinary rounding, I'm finding, because I looked at 2 units whose CPOE is not where I would have expected it to be, and it actually has to do with multidisciplinary rounding, where a nurse is putting in the orders for the day for the intensivist. That's not CPOE. That's a verbal order. And so it's just tanked the orders on that unit. So we're working through some processes to see if we can, shine that up and have the provider putting in the actual orders. So, I mean, it brings up and spotlights some things that you might not have gone back and looked at again anyway.
I do think it's a really good question, though, because the number of hospitals in stage 7 is growing, and the revalidation, recertification is new. As Amy said, they are continuing to evolve. They don't want to add a stage 8. They talked about it, and it's more like, no, now healthcare needs to continue to evolve, and so we have this bar set for what we think excellence is about. We're kind of competitive at legacy, and so we want to achieve that. We measure, so Epic does a number of benchmarks as well, and how well you do in Epic adopting. They have 800 of best practices and what percentage do you have adopted, and Epic Stars is the name of their program, so we pursue that as well. But I think hospitals, you'll decide whether you want to achieve it or not. Fortunately, what I think as they continue the bar higher, like more business intelligence and population health, it is where we're going, and so again, having that external validation, I think, is worthwhile.
Dr. Burdick.
There was some discussion a year or two back, and I haven't followed it since then, about eliminating the need to do both meaningful use documentation or attestations and also the EMRAM and other ones, and just consolidating this to say, do one or the other, and you can get credit for meaningful use dollars by getting to EMRAM stage 7 or something like that. Has there been further discussion about trying to consolidate these?
I haven't
I've
heard
not
such
heard
discussions, but I'd be interested to ask the HIMSS organization about that, because that would be
They
a
would probably like to
motivator.
do it because it would promote more doing that, but that whole meaningful use, we're audited so frequently, and so that all the things you need to do for attestation, I sort of can't believe that the government would give that much authority to HIMSS Analytics to measure your compliance, because it's federal dollars, and it'd be great to, the whole measurement industrial complex, every group is PQRS. I mean, they're just, we're having to slice and dice data. The measures that we give to Oregon Medicaid are different than we give to Medicare. It's insane from a BI perspective and reporting perspective. It'd be great if we could narrow, as you said.
Yeah, and Don Berwick, just in his one of his most recent speeches, was arguing that point, that we're actually decreasing quality in healthcare because of an overemphasis on measurement and the measurement process and the industrial complex around measurement in healthcare.
Well, your point about order sets that have it auto-checked whether you really do it or not is I think.
Questions?
Well, it's the same thing with diagnoses and readmission rates, how you classify specific. So, like, there's a lot of that where I think, sorry, there's a lot of that where I think the reality is that as long as there's carrots or sticks, people will do whatever they can to avoid the stick and to eat the carrot, even if they don't like vegetables. And so electronic tools actually make it easier for you to show what you're doing, because no longer can ignorance be considered an appropriate endpoint, right? It's no longer it's like, well, we don't have a way to document it. That's automatically considered a negative when before it was considered an indeterminate.
Mm-hmm, mm-hmm. Yeah, please.
So we've talked about stage 7 and its meaning to organizations, to even to clinicians. My question is really, do you guys have a sense of whether this is a measure that patients understand, and from Legacy's perspective, how have you tried to market the idea of HIMSS stage 7 to patients, and what kind of responses you've had?
It's a great question. And when we got the designation, we talked to our marketing people about, how do we want to, do the press release? So HIMSS comes out with a press release that they release, and then it's sort of the trade magazines pick it up. But sort of what do we want to do with the Oregonian or anything like that? Particularly being the first in the world or in the country to have EMR stage 7 across ambulatory and clinic. So Kaiser doesn't have that, and so there's a point of local pride in Oregon for this. And our marketing people, I think, very rightly, they talked to a couple of reporters who were like, I don't understand what the public interest in this would be. So, they're there to sell papers, of course. And so, could you put me in touch with a patient whose experience was positive because of this technology, or, and your point, I think there isn't.